Thank you all for joining us for the 6th Living with Liver Disease session. My name is Monica Chewy, and I'm the Director of Development and Community Engagement of the Canadian Liver Foundation, and I will be the moderator and host for this session. I would like to start by acknowledging that the Canadian Liver Foundation's national office in Markham, Ontario, is situated upon traditional territories of the Anishinaabe peoples and of the Haudenosaunee peoples, covered by the Upper Canada Treaties. The CLF's Living with Liver Disease program has been around for more than 25 years, and it continues to serve as an educational tool for both patients and caregivers, but also as a peer support tool. This program provides an opportunity to increase community-based learning about liver disease and the importance of liver health in hopes to reduce the incidence and impact of liver disease through prevention, early diagnosis, treatment, and care without geographical barriers. Speakers include healthcare providers, allied health professionals, subject matter experts, as well as patient advocates. To get a better idea of who our audience members are today and where they are turning in from, we will open 2 short polls that will pop up on your screen. Is everyone done with the poll?
Yes, we're good.
Today's session will address liver cancer. We are joined by our presenter, Dr. Vladimir Marquez from the University of British Columbia and patient advocate, Ms. Angela Robinson. We will have our 2 speakers complete their talks prior to moving to a question and answer portion. Please feel free to use the chat feature at the bottom of the Zoom screen to ask your questions during the presentation, and note that questions will be answered following the speakers' presentations. Following the Q&A, we will be hosting breakout room sessions. This will provide an opportunity for community members across the country to talk about their journeys openly and safely, share insights, stories, tips, and suggestions with others who may be going through the same thing. For those who are not familiar with the breakout rooms, it is a feature within the Zoom platform that allows people to be split into smaller groups within the meeting. The groups are split into regions and provinces, depending on how many people attend. We suggest joining the group that best fits your geographical locations. If you find yourself not sure which group to join, one of our moderators and staff members will assign you to a group. The breakout rooms will be running for about 15 minutes. Today's session will be recorded and available on the CLF's Living with Liver Disease webpage, www.liver.ca/LWLD, as well as our YouTube page in the coming days. In respecting our members' privacy, the breakout room sessions following the talk will not be recorded. For those of you who are new to this program and may not be familiar with the CLF, we are established in 1969 and was the first organization in the world created to help people with liver disease. We are committed to promoting liver health and improving the prevention, diagnosis, treatment of liver disease through our 4 core pillars: research, education, patient support, and advocacy. At this time, I would like to welcome our first speaker, Dr. Vladimir Marquez. Dr. Marquez is a gastroenterologist and transplant hepatologist at the Vancouver General Hospital. His areas of interest include portal hypertension, liver failure, and vascular liver diseases. He's also actively involved in the management of patients with liver cancer. So, ladies and gentlemen, Dr. Marquez.
Good afternoon, everyone, and good evening for those that are in the eastern side of the country. I'm Dr. Marquez, and I would like to thank the CLF for the opportunity to be here today and present this liver talk session on liver cancer. So I will now share my screen. Perfect, reassure. The first question, I guess, and I'm just going to make sure that I time myself to make sure that we finish this on time. How common is liver cancer? Well, liver cancer is very common. Is depending on what you read, it comes up as being like the sixth most frequently diagnosed cancer in the world. But also the third most common cause of cancer-related mortality. It's present in every continent in the world. It touches like everyone, although it may be less common in areas of North America, it's quite common in areas of Africa and also Eastern Asia. This graph just shows a little bit how liver cancer has been a growing problem over the years. We can see the incidence of liver cancer through the time period of 2020, where it has been raising in both women and men, with maybe a little bit of a stability over the last 5 years, and maybe a slight decline, likely tied to the treatments of hepatitis C that we have been able to do in the last 5 years. Now, there are different types of cancers that are liver cancer. The most common one is the hepatocellular carcinoma, which you can see it as being a cancer that originates really from the hepatocytes or the main liver cells. There is the cholangiocarcinoma, which is a cancer that originates more from the cells that are specialized in the bile duct of the liver. We have the liver metastases, which are cancers that originate from somewhere else in the body, but migrate to the liver. And of course, we have other rare cancers that can originate from blood vessels, the lymph nodes, connective tissue also of the body, like what we call commonly sarcomas. Those are really quite rare. We may have mixed tumors of mixed liver cancer or HCC and cholangiocarcinoma as well that can be seen. But definitely the most common form is the HCC or hepatocellular carcinoma. Now, what will increase the risk of liver cancer? The diagnosis of cirrhosis is probably the most important risk factor. And then you have also infections with common viral hepatitis, like hepatitis B, C, and maybe a little bit less commonly D in this part of the world, but in other parts of the world more problematic. Those infections can increase the risk, even in patients that have not reached the stage of cirrhosis yet. Alcohol use and tobacco use are toxins that we know are associated with increased risk of cancer. Aflatoxin is probably something that we encounter less frequently now that there is probably better storage of some seeds and grains, but tended to be an important risk factor in African countries. We are seeing fatty liver being a more common cause or a factor associated with liver cancer, and of course other factors that are associated with liver disease, with fatty liver, including diabetes and obesity, which will increase the risk. Now, what could reduce the risk of cancer? Well, maybe screening, although screening does not reduce the risk of cancer, but mainly helps to detect early stages of cancer. Treatment of hepatitis C will decrease the risk. Vaccination against hepatitis B has probably been the greatest move towards reduction of liver cancer in countries that were endemic. Treatment of hepatitis B, I put a quotation mark, not because it's not necessarily associated with decrease of risk, but because it's we will tend not to use cancer risk reduction as a criteria to decide whether or not someone should be put on treatment or not. Okay, coffee drinking in some recent studies have shown to reduce the risk of liver cancer, but we have to keep in mind that coffee may increase the risk of other medical conditions. Some medications that have also been tied to reduce the risk of cancer, including aspirin, metformin, and statins. But keep in mind that we will not start any of these medications in someone who doesn't need it, just for the purpose of preventing or reducing liver cancer. Physical activity and weight loss, particularly given the impact of diabetes, obesity, and fatty liver, will also reduce the risk.
Can we ask questions on this, or?
I think
you can
so,
save them
but
for
I
the-
think that at the end.
Okay.
Yeah.
In terms of screening, as you know, the goal of screening is to identify patients at an early stage for whom treatment options that could improve survival exist. So to be effective, a screening program should target high-risk patients, be safe to administer at a reasonable cost, be capable of detecting a high proportion of patients with disease, and the disease must have a reasonably long preclinical state. What that means is that there must be a phase that is quite long in which we can detect disease, but patient will be asymptomatic. So it doesn't really work well in conditions that are very aggressive, that very quickly the cancer will evolve. And it needs to show that it can improve health outcomes. So at this moment, who do we recommend to screen for liver cancer? It will be patients with cirrhosis. In patients that do not have cirrhosis, but who have a diagnosis of hepatitis B, at this moment, most of the guidelines are stratifying risk in terms of age and probably some ethnic background, just due to the increased prevalence and epidemiological risk factors that are seen in certain populations. Also, we will screen patients that have a family history in a first-degree relative of liver cancer, and patients with active hepatitis. Patients with hepatitis C, we will screen those that have advanced fibrosis or more advanced scarring of their liver. And there's a condition that is called porphyria. It's a rare blood condition. Will also be recommended for screening. At this moment, the recommended method of screening is a combination of liver ultrasound and a tumor marker that we call the alpha-fetoprotein every 6 months. Now, sometimes in some patients, the liver ultrasound may not be good enough, and we would recommend in these specific cases to do MRI screening. But we don't use MRI at this moment for general screening of everyone that meets criteria for screening. Now, although we do recommend screening, there are still questions about the efficacy of screening HCC, and those are due mainly to some conflicting data in the scientific literature. We don't necessarily have good quality clinical studies that really conclude that screening really works. But in the absence of anything to tell us the contrary, we still recommend screening. Now, usually we will not screen patients that are older, although we can also adjust that depending on the potential life expectancy of a patient. And we will not screen patients with very advanced liver disease that are not candidates for liver transplantation, because we will simply not be able to give them any form of treatment for their cancer. Now, why age is it's an important criteria, because we know that the risk of cancer, of liver cancer, really increases as we get older. So it's very, very low in people that are less than 50, and it starts increasing more at the age after the age of 50 and beyond the age of 65 years old as well. Now, why do we say that probably screening may be beneficial? Because it allows, or the purpose of screening is to allow the discovery of an asymptomatic lesion, something probably at its early stages. And we can see from this graph that the long-term survival of the patients are is tightly related as to the how early it was detected. So when it's early or localized, patients have a longer survival potential than those in whom, unfortunately, it was diagnosed when it was already spread. Now, I will go to a quick overview of treatment options. I mean, this is a very broad and very large subject. So when we decide about treatment choices for liver cancer, we have to take into consideration both the tumor burden, but also the liver function. HCC management, it's probably one of the few cancers out there, if not the only one, in which the function of the organ is important to decide what kind of therapy we can use, given that the sensitivity of the liver to injury from or from toxicity of the treatment. We divide the strategy for treatment into three main options. One is surgical, where we can resect the tumor, or transplantation, which is the replacement of the whole organ. Locoregional therapies are therapies that that target the tumor directly. So we go and directly try to attack or burn the tumor with different types of methods. And systemic is more something that is taken that will have an effect on not only targeting the liver, but that could eventually, have an effect and side effects to other parts of the body, because it just circulates into the patient's bloodstream. So for surgery and or resection, we usually will use this in patients that have what we call a preserved liver function. So early stages of cirrhosis, or maybe not cirrhosis at all. And we need to be sure that we will be able to remove all the tumors from the surgery, and that there will be sufficient healthy liver tissue left for good function. So, of course, the outcomes of surgery are really tied to the size and the number of lesions, as well as the liver function of the patient. So it's not offered necessarily in everyone, because a lot of times the patients have conditions that will increase the surgical risk. Now, sometimes in those patients, we will use locoregional therapies. And one of them is ablation. So ablation, it's really, it can involve radiofrequency ablation, microwave ablation, cryoablation, so using, instead of heat, cold. So those are all what we call ablative therapies. Previously, we also used alcohol to burn the lesions, but we don't use it as frequently as before, if not at all. This technique basically is either done with ultrasound guidance. It can also be done with a minimal surgical incision, a minimal surgery, but with the same approach, where we detect where the tumor is using an ultrasound, and then we go with a probe that has a very long needle. At the tip of the needle, there is these different ends that will start rotating. And create heat to burn the tumor. The best outcome of this technique is in patients that have 1, maybe 2 lesions, and really less than 4 centimeters in size, although the best results are seen in lesions that are 3 centimeters in size. Whether or not we can use this will depend on where the tumor is located in the liver. And we have very, very good results for complete ablation of the tumor, or burning of the tumor. Although there may be a little bit of recurrence that With this kind of technique, we end up having very good 3 years and 5 years survivals for as long as there are no other problems related to the liver function. When someone is not necessarily candidate for a radiofrequency ablation, we also have what we call transarterial chemoembolization. We call it TACE for short. And what we do in TACE is that we go through the artery in the groin and we thread a long catheter to where the blood vessel that is feeding the tumor. And then we will deliver a chemotherapy drug directly to the tumor, to the bed of the tumor, and then we're going to clog the access of blood to the tumor. So we will send chemotherapy, and we will do what we call embolize. So we will choke or prevent blood flow to go to the tumor. We must have a good preserved liver function for this. We must not have clots in the main portal vein, the main vein that goes into the liver. And we use it for patients that have a larger tumor or more lesions that are located in one area. But if the tumor is too large, it may not be effective. And as I said, we can use it for people that have more than one tumor or what we call multifocal lesions. So this is basically the explanation that I just did for how the technique for TACE works. We have relatively good results with TACE in that we can control the growth of the tumor. And sometimes, although we cannot treat it completely, we cannot make it disappear, we may be able to shrink the tumor in a way that we can consider other treatment modalities, including the possibility of transplantation. Radioembolization uses the same approach, or really the same idea than chemoembolization, but instead of using chemotherapy, the beads have a radioactive material that when it will be delivered to the tumor, they will send their radiation therapy, but from inside as opposed to an outside ray of radiation therapy. It can be used for larger tumors than TACE. It can be used in patients that have the blockages of the portal vein, but still must have a good liver function. It can be used for larger lesions than TACE, and it's probably safe, maybe a little bit safer than TACE, but we are not, or we don't have sufficient data yet to know that it's necessarily better than TACE in terms of survival. SBRT is also a novel technique, or well, not that novel, but it's something else that has been developed, which is external radiation therapy. And using a very specific technique, we can deliver high doses of radiation in a very, very precise area. We are getting more and more experience with SBRT, with good control of the tumors, even after a few years following treatment. That being said, it does not prevent tumors from growing in other areas, appearing in other areas. So that may limit the capacity or the utility of SBRT. Now, when we move to systemic therapy, it used to be oral therapy. There may be now more intravenous options that may be available, but it's typically for patients who have developed disease outside of the liver. Or we can use it as a supportive therapy with patients that have advanced tumors or larger tumors that are localized to the liver. We have a survival advantage that has been demonstrated, but mainly in patients with preserved liver function. So as you can see so far, one of the common themes of all the therapies that I have named so far is that we need to have a good liver function. Now, in terms of systemic therapy, we are having a new medication or new combination of medication that is now used as first line because it has good better results in terms of overall survival of patients taking the medication, and also in the progression of the tumor over time. So what is interesting is that since the development of the first-line therapy for liver cancer in 2008, there was a period of time where nothing was really found that was new. But in the last 5 years, there has been development of several new medications that are effective for against HCC that are now being used in first or second line for those that are non-responders to the first-line therapies. So we are having better results in terms of treatment than before. So we have better 1 year, 3 years, and 5 year survivals than what we had just 20 years ago. So treatments are improving for liver cancer. And that irrespective of how early the tumor was detected. Of course, the results are still better in patients that have had early detection, but even in those that have had more advanced disease, we are seeing better survival. Now, liver transplantation, I mean, it's a complex chapter as well, but it's not necessarily for everyone. We cannot use it in patients that have tumors that are outside of the liver. We will typically use it for patients that do not have that preserved liver function that allows them to have any of the other therapies that I described before. Or sometimes we will use it in patients that have had several types of therapy, but that had recurrence or not necessarily the complete responses that we wanted to see. Now, to be able to offer transplantation, the amount of tumors, the number and the size has to be limited. There are several different criteria that are used in different transplant centers, but the most common one is what we call the Milan criteria, which limits the number of tumors to only one that should not be greater than 5 centimeters. And if there's more than one lesion, it cannot be more than 3, and not any of them can be greater than 3 centimeters of size. Sometimes we're using the alpha-fetoprotein to help, although it is not a specific criteria yet with Milan. But why we use this criteria is because we know that if we transplant someone beyond a criteria that has been set, there is a higher risk of recurrence of the tumor in a very aggressive form after the transplant. And because of the immunosuppression that is given after the transplant, the tumor will just like spread, and the mortality is very high, and no treatment is really effective at controlling that. Sometimes when necessary, we do what we call downstaging. So we can try to shrink the tumors to bring someone within the criteria of transplantation. If someone is within the criteria of transplantation, sometimes we do what we call bridging, is treatments to try to prevent the tumor from growing outside of transplant criteria. All these cases are obviously discussed at a liver tumor board. We try to individualize the treatment recommendation to the specific presentation of the patient. And although I described several treatments, these modes of therapy can be used in sequence, but they can also be used together in parallel. We can do like ablation of one spot and SBRT of another, resection of one and radiation of other. So sometimes we do mix these types of therapy. And yeah, that's, I think, the end of my presentation.
Thank you, Dr. Marquez, for that very great and informative talk. So for those who join us after we started, please hold off your questions until the end. We would now like to welcome our second presenter, patient advocate, Angela Robinson. I hope Angela is here. Angela great. Hi, Angela.
Hi, Monica.
Angela was born and raised in Calgary, Alberta. In 2000, doing a regular swab for an insurance plan, she discovered she had hepatitis C. She fought a long path through liver cancer, then a liver transplant. She was lucky to receive a transplant in 2011, and she hasn't looked back since. She is thankful for her second chance at life, but is adamant that more research is needed, which is why it is so important for her to volunteer her time with the Canadian Liver Foundation and other agencies to help raise awareness and funds. So Angela, over to you.
Hello, everybody. Okay, yes, like Monica said, my name is Angela. I am now 60 years old. I was just screening for insurance, and I was absolutely dumbfounded that I was a healthy woman. I was a single mother. I was self-employed, and then I found out I had Hep C. So that started my journey. And I think it was about in that same year or the next year that I met Dr. Burak, and he took me under his wing and said, everything's going to be okay. And we got started on a program of trying drug trials for treating the Hep C. Back then, they weren't very successful. I think the first drug trial I did had the injections as well as the oral therapy, and it was very long. And soon into it, they found that I had a genotype 1, which was not receptive to the treatment. So they stopped that. And that's when the first time that it kind of dawned on me that research is key, because he said, you hang in there, you get healthy, and in 10 years, there will be a new treatment. Well, probably 10 years to the month, maybe a few months, I went into liver failure. I had been doing well, but kind of fell off the radar. You know, I do my regular checkups, but just thought everything was going to magically go away. I had been visiting my daughter in Calgary, and I was living in Manitoba at the time, and she was on her own. And she was about to go traveling, and so I was staying at her place. She was going to work one morning, and obviously I was in liver failure, and she suspected something. So she went to work to open her bar and then asked her manager to take over, and she was coming home to get me. But in the meantime, I went into complete failure and ended up in the hospital. And that's when I was sort of fast tracked through Rocky View and then over to the foothills. And that's when they were doing all the screening and whatnot. And I was told that I had the HCC, hepatocellular carcinoma. So then I was really under Dr. Burak's radar, and for the next, and I'm hard on timing and years because that part of my life is really fuzzy. But they tried I did 2 sessions of TACE, and I had 2 tumors, and they were small. I can't remember, like around the 2 centimeter thing. And the 2 TACEs did not work, but the RFA worked in getting a reduction. But in the meantime, I was, doing my regular appointments, such and such. And they said, because of the cancer not going away, I don't know if they still have it, but they called it the MELD score. I think it's called the Model for End Stage Liver Disease or something like that. And I was sent up to Edmonton to do the workup with Dr. Shapiro. And he said at that time, he says, with your cancer and the stage 4 of your liver cirrhosis, you have at the most 2 years to live. So he said, we're going to get you worked up for a transplant. So that's what happened. And the next 2 years actually, I got my transplant in 22 months. So almost 24 months. And at the end, I was not doing so well. I was sleeping 18 to 20 hours a day. I couldn't hold conversations. I had encephalopathy. They took away my driver's license. Well, didn't physically take it away, but just said, you don't drive. So I just worked on being as positive as I could, stayed away from the internet for sure. If they said jump, I said how high. And I just had a faith and a belief that I was going to get my liver. And the kind of funny thing was, it was December 1st, 2011, when I got my call. So over the 2 years, imagine they have you all gung ho and you've got your bag packed, it's at the door. And then after a while it gets moved to your bedroom. And then after a while you unpack it all together because you think, whatever. And sure enough, I get the call and I'm not packed or anything. But the reason that I got the call was because I still had hepatitis C because I couldn't treat it. I had the cancer and I was, my MELD score was pretty high. I can't remember, I think 24 or 34. I don't know what it was, but pretty high. And the liver had actually been offered to somebody else first. And that person declined because they didn't have hepatitis C and didn't want to get it. I jumped at the chance because I said, hey, I've already got it. I don't care. And I was also, told all the way along that not to worry because once I got healthy from my transplant and I was cancer free, because of course the cancer goes with the liver because it was all inside, that there was new treatments coming down the pipe. So I hung in there and I did so well during my transplant. I was out of the hospital in 21 days. I was only in ICU for 19. And I went, home and did everything they told me to and became probably healthier than I've ever been since. But I just, waited and waited. And then in 2013, I was presented with a hepatitis C treatment, which was one of the last worst ones. It was 48 weeks and it was awful. They almost took me off of it, but I was so determined that no, I had gone through this. I know you told me there's more drugs coming down the line. Like I think now treatment for hep C is like 10 days, something ridiculous, but I did not want to waste this liver and take any chances. So I did this treatment, I lived through it, and I got really involved with Deborah Lee Furnetz at the Canadian Liver Foundation, and became one of her best volunteers. I think even one year I got Volunteer of the Year award or whatever, but I mostly just want to do it for the education. I want people to know that there is hope. There's always hope. Not only do you listen to your doctors and follow their treatment suggestions, but keeping a really positive attitude. And like I said, staying off the internet, don't do any research, let the doctors do that. And then just go ahead and live your life. And I had never been like a walker or a runner, never a runner, but I think I've done, Deborah Lee has a program, or did until she retired, Give Her for Liver. And I think I did, I don't know, I'm going to say 5, maybe 6 half marathons with her, just walking, but we got through them. And to this day, I'm still a very, very avid walker. Exercise is key, and taking your meds, do what they say. You have to be compliant, or, they're just trying to do the best that they can for you. So that's my story. I'm 11, no, so what? I can't do my math. 11 years post-transplant. December 2nd will be my 11 years. And I'm on a very low dose of anti-rejection. I only take 1 milligram of Advograph, which is a slow release. So I don't have any side effects. I've never had any complications. Up until COVID, nobody that I work with even knew that I had a transplant, because I just didn't want to bring that there. But everywhere else, I'll talk about it. I go to sessions, or, Deborah Lee or Carrie Fernell will phone and say, hey, there's somebody going through this. Would you talk to them? And I say, absolutely. I'd love to share my story, because no matter how bad it gets at the end of the day, like I said, at 22 months, I was pretty bad, but I always had hope, and here I am. So that's about it. Any questions?
Thank you, Angela. Thank you, Angela, for sharing your story.
You're welcome.
Good
Happy
to
to help.
see you. Yeah, miss your
Thank
smiley
you.
face. Thank you for all the volunteer work you do for the CLF too in,
You're welcome.
Calgary. Yeah. So now I would like to invite our speakers to join us again on camera to answer some of the questions from the audience. So Nam, my colleague in the Toronto office, the national office, will help me moderate all those questions.
Actually, I just have a question quickly for Dr. Marquez. There was a question earlier with respect to hemangiomas. Perhaps you can maybe explain what a hemangioma is for the audience members who are listening, and if that's considered something serious or cancerous for that matter, and what perhaps are the next steps in terms of either treatment or prognosis.
So hemangiomas are benign liver tumors or liver masses, for lack of a better word. So they are basically a malformation of blood vessels in an area. They will be the liver equivalent of sometimes we see people with hemangiomas on their skin, you know, the like sort of the famous wine spots that people may have. They may have like a reddish discoloration in their face, or a reddish discoloration, just like the Gorbachev had on his forehead. That's a hemangioma. It's just a malformation of blood vessels, and it happens that the liver does tend to have that developing fairly frequently. We see hemangiomas in approximately 25% of the population. They are benign. They don't have a potential to become cancer with time, and they tend not to give symptoms, even sometimes when they are quite large. Now, it happens that because of their location within the liver, that because of that specific location where they are, that if they grow to a certain size, that they may give some symptoms. They may give like a little bit of pressure feeling, or maybe they push into the stomach and give symptoms like that. But unless they give symptoms, and unless we think that then those symptoms are caused by the hemangioma, we don't do anything about them. So once we find them, once we see that these are hemangiomas, usually we just forget about them. Like we don't recommend a follow-up imaging to see if they're growing, or if more are showing up. We just try to forget them. And then if at some point, you know, the patient comes back and says, oh, I have this symptom, then we reassess at that moment whether or not it could be the hemangioma that is doing that. But then, you know, like, I'll be honest, if we have a 2-centimeter hemangioma, that will never give any symptoms. Okay, we're talking things that will grow to like 10 centimeters and beyond of size. Okay? So yes, they're common, they're benign. We tend not to worry about them or try to forget about them.
Thank you for that, Dr. Marquez. Very definitely helps those folks have those questions. And as I'm sure people can imagine, when they either see something of that nature on an image or a scan, the panic triggers pretty quickly, and some of those questions arise. So clarifying that is definitely helpful. Maybe to question for I guess for Angela, at the foundation we get quite a bit of the questions in terms from the caregiver perspective, or a loved one or a family member. What would you say in terms of how important would that be, or was that in your journey? And what would you perhaps say to some of the caregivers who may be tuning in or who watch this video afterwards, how they can help support somebody who's perhaps going through the cancer journey, whether it's before, during, or after following transplant?
Sure. So when I went into liver failure, of course, as I said, my daughter was going to go to Thailand, and she wanted to cancel her flight and everything else. And I said, absolutely not, because I already knew that this was going to be a long journey and that she would have to look after me when she got back. So she was gone for, I think, 2 or 3 months. So when she got back, we moved in together. We got an apartment together downtown in Mission in Calgary. And honestly, I permitted her to be my caregiver because, you know, it's a reverse role, right? I'm her mother. I should be looking after her. But we did really well together. I always called her my organizer bunny. She had a binder with all of my appointments and reminders. And did you take your pills? And I mean, she was only 18 years old, and she was forced. I didn't want her to, but she was forced into looking after me. So I just did my best to support her in whatever way I could. I made sure I cooked for her and me because I love to cook. I used to bake a lot ever since my transplant. I can't stand sweets. I don't know why. Maybe the liver I got didn't like sweets either, but so it became a mission for me to look after her because she was looking after me. And really she did the lion's share. But I went to support groups and just tried to encourage her the best that I could, as far as, like she was the one that kind of squealed on me and said, my mom can't drive anymore and it's going to kill her. But she did it because she knew it was in my best interest and hers too, because I used to pick her up from work. But we just decided to be a team. And honestly, we had this binder thing going, and she would add all of, my tests, and she had it all, whatever. She was just organized. So organized, in fact, that she even had a list of all the people that when we got the call, that she would make the calls and do all of this. And then we even started something. We used to have so many laughs, but we started my funeral playlist for songs. Like, top of the one was like, okay, Stairway to Heaven. And then one time too, I took myself to all 3 of my cancer treatment at Foothills. Like the first time I went, I pulled into the parking lot and the guy said, I'm sorry, this is reserved for handicap and cancer patients only. And I said, oh, okay. And I stupidly drove around, and then I got halfway around. I thought, wait a minute, I'm going in for my cancer treatment. So I pulled back up and I said, you're going to laugh. But I said, I'm going in for a cancer treatment. And I said, I don't want to park like a mile away because I'll get out tomorrow and I won't want to walk. Right. So he laughed. So I said to my daughter after that, I said, every time that something like this comes up, I'm just going to hold the letter C up in my hands and we'll call that the cancer card. So we would use it like to skip a line or I don't know, funny things, right? But anyways, my point was I was trying to support her in the way of, love and the fact that I knew what she was giving up for me. And I went to support groups. I found support groups for her. She even did a marathon for the Giver for Liver in New York when I was like my sickest, because she felt that raising money for research was just that important. And then the last thing I want to say is that when we got the call, we were both in the bank actually trying to pay our rent that day. It was December 1st. And she was so like, I was like, oh, calm, good, let's go. Went home, we got packed. She was an absolute wreck. So I actually drove to Edmonton to get my transplant. She sat in the car in the seat and like cried and laughed and called everybody and all of that, right? So yeah, at the end of the day, we were just there for each other. And to realize that the caregiver, in some places, the caregiver is giving up more and doing more work than the actual patient is. So it's important to get that support. Thanks.
Thank you, Angela, for that. If anybody has any other questions, by all means, we have maybe a minute or so left. And if not, we can definitely discuss some more aspects in some of the breakout rooms if there's some more specific questions that people want to talk with others. But we had maybe 45 seconds if anybody wants to ask any specific questions. And if we don't hear anything, we'll just move on.
I will just make a comment to what I just heard, and I think that yes, the caregiver or the social support is a essential and component of the after transplant care of a patient. It is so important. It is so important and critical that if we do not have a good social support person, a reliable social support system, that could prevent someone to get on a transplant list. Because we know that patients that do not have a social support do not do well after transplant. So yes, I think that she nailed it when she said, like the support person ends up doing more work than the patient itself. It is true.
Thank you for that. Monica, we can go ahead.
Okay, so with that final comment from Dr. Marquez, that concludes our educational session for this evening. I would like to take this time to thank both our speakers, Dr. Marquez and Angela, for your great talks. As mentioned, this session will be available on the CLF Living with Liver Disease webpage and the YouTube channel over the next few days. So join us for our final session of the year in November on navigating the healthcare system, a very important one. For more information on upcoming sessions and to register, please visit the liver.ca/LWLD page at the start of each month. If you don't see the session posted yet or minimal information, please do check again in a few weeks, and we are likely finalizing speakers. So now we're going into our breakout rooms. At the bottom of your screen, you will see a button that says breakout rooms. Please click the button and give it a few seconds before you see the different groups available. The groups will be split into regions or provinces. Some will be grouped together depending on how many attendees we have. Once again, we suggest joining the group that best fits your geographical location. We will have our CLF staff across the country moderating the breakout rooms. Bear with us a few seconds as we get the rooms set up. Once you see the groups on your screen, please choose your group, click the Join button on the right. If at any point you need to leave the room, simply close the room and or the meeting. So Dr. Marquez, I know you have more work to do at the hospital, so you might not be able to join our breakout session, right?
Yeah, I'm on call.
Okay, all right, thank you. We won't take you away from the patients. Angela, you'll be joining us, correct?
Yes, sure.
Awesome.
Thanks, Dr.
So,
Marquez, for everything.
No problem, no problem. Are you still seeing Kelly? Kelly,
Yes.
Burrett? Yeah.
Yeah, I have other doctors too, because he's pretty high up there, but he's one of my favorite people.
He's a great guy. Yeah.
He's a great guy. Yeah.
awesome. So thank you, Dr. Marquez.
Thank you, Monica, and thank you
We'll
to
talk to you
CLF.
soon. Yeah.
Thank you.
Thank you.
So then, okay, so we are ready to go into our respective breakout rooms, right, folks? Okay. I think everyone is back to this main room now, right? So once again, thank you everyone for participating in today's peer-to-peer breakout rooms and for attending the Living with Liver Disease session on the topic of liver cancer. Should you have any additional questions or comments or simply want to stay up to date on everything liver health related, please connect with us via our social media channels highlighted on the screen or send us an email at clf@liver.ca. So we want to thank our sponsors and of course a big thank you to all those who attended tonight's session. Have a great evening, everyone.